classical and unusual presentation of atopic dermatitis, to be presented by Dr. Abhijit Saha, consultant pediatric dermatologist at the Institute of Child Health, Kolkata.
Thank you, Arpita. And it's 12, so good afternoon all. First of all, I want to express my sincere gratitude to Dr. Dhar for having me here. And many of my photographs actually lended by him only. So today my topic is classical and unusual presentation of atopic dermatitis. Now, when I've been asked for this topic, the first question came into my mind: why we need to know all the varied phenotypic presentation of a common disease like atopic dermatitis? I mean, it's a very common disease, and it often present as typical flexural dermatitis in our day-to-day practice. So, and I can vouch, almost all of us, if not all, present in this auditorium can diagnose a typical flexural dermatitis of AD with a blink of eye. So why it is needed to know all the varied presentation? There are several reasons. Firstly, the classical description given in any standard Western textbook doesn't fit always with our kind of patient. That means a patient of skin of color. For example, erythema is much less perceptible in our kind of patient. Secondly, as we all know, atopic dermatitis poses a profound negative impact on the quality of life. It's an extremely itchy condition that leads to sleepless night, poor scholastic performance, growth retardations of the babies, financial burden as far as the cost of the therapy is concerned, financial loss, working day loss of the parents, so on and so forth. So if we can treat the disease at the earliest, we can reduce the severity of the disease, hence we can improve the quality of life. Secondly, fortunately, 70% of the AD patients outgrow the disease with age, but there is a subset, 30% of them may develop other allergic diseases in near future, that is called atopic march, all of us quite aware about. So if we do not miss even a single case of AD, then obviously we can initiate the treatment promptly, and there is always a chance to prevent the future development of other allergic diseases. Thirdly, for last few decades, we have been experiencing an unprecedented increase in the prevalence and severity as well, courtesy to our inclination to the Western culture. We are very concerned about our hygiene. We opt for cesarean section. We feed our baby with formula feeding. We prefer more and more Western foods. We are very particular about the routine immunization of our babies, and often every now and then we pop in antibiotics even without a reasons. So all these things actually deviating our babies from being exposed to soil, dust, debris and obviously beneficial bacteria in the early phase of life, which is extremely important for activation and maturation of the immune system. Does the story end here? Definitely not. There is the other side of the coin. If you type research in AD in the last 10 years on Google, you will see the net will flood with number of numerous articles. That means extensive research is going on across the globe on different aspects of AD, including its phenotypic presentation in different ethnicity. And global leaders of AD, including our own Dr. Dhar, they have devoted their life on research of a single disease called AD. That's why every other day we come across something new about AD. But the picture was not that much exciting few decades back. Probably at that time we were not that much versed about the unusual and minor presentations of AD. We could have missed those cases, or we could have labeled them as something else. That's why the prevalence data at that time might not be the true reflection of the actual prevalence. And this is one of the landmark studies done way back in 1998 by Dr. Dhar and Dr. Kanwar on epidemiology and clinical pattern of atopic dermatitis. And today we are actually replicating, you can say, repeating the same study under the able leadership of Dr. Dhar under the umbrella of Society for Eczema Studies. And we just want to see the current prevalence, severity, and clinical pattern. We need to wait for some 1 year or two, and probably we will get to know much more about the current status. So with this prelude, let's begin our journey proper. Coming to the classical presentation of AD. So this is a classical presentation of infantile eczema involving both of the faces. See, on the other day, few weeks back in Lucknow, we were discussing, whether which potency of topical steroid should be used, whether topical steroid antibiotic combination were used or not. I am sure our brilliant moderator, Dr. Samanta Budwa sir, will bring in those things in his moderation. But one thing I just want to highlight, my previous speaker, Dr. Rajim Malakar, has already mentioned. Baby skin is very thin, number one, and they have increased body surface to weight ratio. So there is always a chance of high percutaneous absorption. Excuse me, can I have some water? Therefore, there is always a chance of development of cushingoid feature like this, along with the something like this, and depression of hypothalamo-pituitary axis. So, at any case, any unchecked or unsupervised use of topical steroids should always be discouraged. We have been told repeatedly since yesterday morning, every speaker is actually hitting on the same thing repeatedly, that topical steroid use should be very much judicious. Again, infantile eczema involving extensor aspect of the extremity of a baby. This is the classical presentation of childhood eczema involving the flexure. Again, if we want to categorize different type of eczema, it could be acute weeping, oozing eczema like this, or it could be a bit drier erythemata scaly, and in extreme case, it could be lichenified one. Lichenification, as we all know, skin will be thickened with prominent markings associated hyper or hypopigmentation. And this kind of lichenification is actually very difficult to treat. I am sure Dr. Barua can bring this topic about our personal preferences and experience regarding treating lichenification. Coming to the minor features of AD. Again, xerosis is an almost constant companion of AD. Sometimes you may get to see some fine scales, and many times you need to touch and feel the baby. What we need to do, that is counseling of the parents and motivate them to use moisturizer liberally. Hyperlinearity of the palm. As we all know, there are certain endotypes or risk factors for development of atopic march, like severe AD, like early onset AD. Similarly, in that sense, this hyperlinearity of the palm can be considered as a marker, cutaneous marker for future development of severe AD and filaggrin gene mutation. So that should be kept in mind. Follicular prominence. Again, the parents will rush into your clinic with so much apprehension that, see, doctor, my baby is having this kind of small tiny bumps over the skin. Again, you need to reassure them this is not a disease. Your baby's skin is structurally something different. So you need to use moisturizer regularly and liberally. Again, any kind of hypopigmented patch over face or any other body part for that matter actually raise the eyebrow of the parents and actually create a lot of apprehensions regarding the fearful disease called vitiligo. So again, we need to reassure them, this child's skin is very dry, you need to moisturize it, and along with proper sunscreen and pimicrolimus, this problem can be solved. Keratosis pilaris, a very difficult to treat condition, but please remember, keratosis pilaris can be seen even in normal children without any atopic dermatitis. Cradle cap. See, this kind of yellow, greasy, sticky scale over the scalp, if you see, immediately you jump into the diagnosis of infantile seborrheic dermatitis. Yes, it is. And if you look at the other body folds, you are almost certain about that your diagnosis. Yes, it's a case of ISD. But please remember, cradle cap is not pathognomonic of ISD. It can occur even in atopic dermatitis too. And in that case, cradle cap would be a much more drier, crusty, fissured, and itchy. Ichthyosis vulgaris, one of the minor features of AD, but please remember, it's as you all know, it's due to filaggrin protein deficiency, and 20 to 30% of our patient, of ichthyosis vulgaris patient, may develop AD in near future. So they need to be followed up regularly for the signs of AD. Now coming to some varied presentations. Eyelid dermatitis. You can see bilaterally symmetrical eyelid dermatitis of this child. And due to vigorous rubbing, the skin fold got thickened. Here we need to remember one important point, especially in adolescent girl or young girls, they should be prohibited to use any nail polish or any kind of eye makeup. Otherwise, you are actually aggravating any pre-existing dermatosis with a superimposed allergic contact dermatitis. Atopic cheilitis, again, an extremely difficult to treat condition. Irritant contact dermatitis is very much common in AD because all we know, due to impaired skin barrier and due to saliva and acidic or alkaline wet food. And this is the presentation: erythema, scaling, fissuring, etc. Irritant contact dermatitis may also develop when there is nasal congestion and when the baby is a mouth breather. Due to repeated lip licking, repeated episodes of wetting and drying, this may can occur. And as I've shown you the previous picture, secondary to the atopic cheilitis also, these lip lick dermatitis may occur. And diaper dermatitis as a presentation of atopic dermatitis is extremely rare. Why? For the simple reason, this area is occluded, moisture is too much, and inaccessible to scratch. That's why diaper dermatitis as a presentation of AD is extremely rare. If it happens, then it would look like as primary irritant contact dermatitis involving the convexities, as you can see, convexities of the surfaces. And in that case, it would be extremely resistant to treatment, extremely pruritic condition, and obviously you will get other signs of AD elsewhere or other body parts, family history of AD, so on and so forth. Allergic contact dermatitis, difficult. Previous concept was that allergic contact dermatitis doesn't occur in AD, but nowadays we know it can also occur in AD. But how can you understand that baby has allergic contact dermatitis? Either the baby will not respond to topical steroid, or the topical steroid will aggravate the condition. This is the clinical clue to suspect any case of allergic contact dermatitis happening. And in that case, you need to do the patch test to confirm, though patch test is also not confirmatory in each and every case. Forefoot eczema, you can see the forefoot is erythematous with glazed, shiny appearance with multiple fissures. Baby may present as head and neck dermatitis, which can be mistaken as seborrheic dermatitis. Here a course of oral itraconazole would be very much beneficial. Penoscrotal fissure could be one of the presentation. Retroauricular fissure, you can see, and probably this is one of the condition where we advocate use of topical steroid and antibiotic combination. As my previous speaker, Dr. Malakar, has said, it should not be used routinely, but here we can use it. Nipple eczema. It was known previously, nipple eczema or breast eczema, that actually occurs in adults, but please remember it can also occur in children. And another presentation is frictional lichenoid dermatitis over the friction areas like elbow. Baby may present with scalp dermatitis, and due to vigorous rubbing of his head against the pillow, the area got inflamed and swelled up. Again, there is an age-old concept that lichenification develops during the late childhood or early adulthood, but this concept has nullified nowadays. The picture is self-explanatory. It's a proof that even a small baby like this can scratch vigorously, rub vigorously, and you can see the vulva get rippled and lichenified. It can present as follicular eczema. Posterior thigh dermatitis. By definition, posterior thigh dermatitis is the one type of allergic contact dermatitis. But nowadays, we are getting more and more cases of AD patient presenting with this posterior thigh dermatitis. So I don't know whether our moderator sir will continue the debate or not. Really it's a presentation of AD or it's a different entity. I leave it to him only. Another very characteristic feature of AD of skin of color is AD patient heals with hyper or hypopigmentation. You are bound to get a kind of dyspigmentation, either hyper or hypo. And again, in contrast to the common belief that discoid eczema is a specific entity, actually it has been proved that an atopic child can present with multiple patches of discoid eczema. Unless and until unless and until he or she is an adult patient, discoid eczema should not be considered as a separate entity. It's no longer a truth. If you get this kind of excoriated papules over the exposed body part like face, like waistline, you must look at the most exposed body part, that is both of the limbs, and you will get this articulated papules. And some of those are so itchy that they are being excoriated like this. Again, this picture speaks 1,000 words, so you can see the degree of involvement. Even some of the lesions over the waistline become nodular. Itching is so intense. So here, first and foremost thing, you need to advise your patient, and you need to do it repeatedly in each and every follow-up visit, that full covered cotton cloth is what is needed. Babies like to play during the evening or afternoon, so you have to repeatedly stress it upon the parents that your baby should be fully covered, as nicely shown by Dr. Malakar in his presentation, how it should be, full covered cotton clothes. And long-term antihistamine therapy, what is needed. This is a story of a 17-year-old boy, just started his career as hairdresser, and within few months developed this kind of severe hand eczema. So hand eczema could be a presentation of adolescent AD. Not only adolescent people, even a child can present with hand eczema. Those who are on sensitive to nickel, cobalt or chromium containing diet, that is systemic contact dermatitis. Since yesterday, I know many of us they got the prize of chocolates. So if any of you get systemic contact dermatitis, don't blame me because I have not given chance to speak before. Otherwise, I could have warned you not to take chocolate. It contains a lot of nickel. Now coming to the severity, by definition, when the scorer is very high and when the skin involvement is extensive, just like this, it can be considered as a severity. But my question to you, if the involvement is that much localized, but at the same time it is impairing the quality of life of the child so severely that he cannot concentrate, cannot sleep, cannot go to school, cannot even open his eyes, do you consider it as severe form of AD or something like this? See the face of the baby, he is helpless, his eyes are full of tears. If you ask me, yes, I will consider it as a severe form of AD, and if needed, I will not hesitate to give short course of oral steroid or cyclosporine to relieve his symptoms, followed by obviously moisturization and other measures. This 11-year-old girl was a known case of AD, suddenly become toxic with high rise of temperature and develop so many vesicles. You can see around the eyes, and some of the over the pre-existing atopic patches, and some of the lesions are hemorrhagic. So it is eczema herpeticum. Extreme emergency, we should start IV acyclovir without a delay. Otherwise, we may we may lose the child. And when AD is presenting very early, even at birth or within the first few weeks of age, even before the standard age of appearance, and along with if there is several infections, several episodes of otitis media, recurrent sinopulmonary infection, long-term antibiotic therapy, patient is not responding, there is need of IV antibiotic, if the baby is not gaining weight properly, or if there is family history of this kind of things, then you should consider primary immunodeficiency. So this is my last slide. The more you sweat in training, the less you bleed in battle, and that is my motto. And this kind of August gathering actually the best place to learn from. Now as I can see, there are a number of stalwarts sitting in front, and this is actually my opportunity, my privilege to learn from all of you due to sharing and mutual reciprocation. Thank you very much for your patient hearing. Thank you.